Hello everyone, now we'll discuss about Mirizzi syndrome. Recently whatever I have covered, the steps Mirizzi, they are all in the 2024 paper. Mirizzi syndrome is a rare complication of long-standing gallstone disease, the cholelithiasis. It occurs when a gallstone becomes impacted in the cystic duct of the neck of the gallbladder, that is the Hartmann's pouch. This causes extrinsic compression of the adjacent common hepatic duct, leading to obstructive jaundice. Over time, the chronic inflammation can erode the walls of the ducts, resulting cholecystocolidocal fistula, an abnormal communication between the gallbladder and the common bile duct. The image shows the Mirizzi syndrome, the impaction of a large stone in the neck of the gallbladder causing obstruction at the level of confluence of the cystic duct and the common hepatic duct. Pathophysiology: the condition progresses through distinct stages driven by chronic inflammation. Number 1, impaction. A large gallstone becomes permanently lodged in the cystic duct or the Hartmann pouch. The second, extrinsic compression. The stone and the resulting localized inflammatory response press against the common hepatic duct, narrowing its lumen. 3. There will be obstruction. Bile flow from the liver is blocked, causing proximal bile duct dilatation and clinical jaundice. 4. Fistulation. Persistent pressure necrosis causes the wall between the cystic duct, gallbladder and the common hepatic duct to break down. This results in formation of fibrosis, ulcer, fibrosis, erosion and then fistula. Clinical features: patients typically present with symptoms resembling acute cholecystitis combined with biliary obstruction. Jaundice, intermittent or progressive, yellowish discoloration of skin and sclera is noted. Right upper quadrant pain, often severe and radiating to the back or the right shoulder. Fever and chills occurs with secondary bacterial infection leading to acute cholangitis. There may be even nausea and vomiting. Diagnostic evaluation: preoperative diagnosis is crucial because unrecognized Mirizzi syndrome carries a high risk of accidental bile duct injury during surgery. Lab investigations: LFTs, marked elevation of serum bilirubin, obstructive pattern, alkaline phosphatase, and gamma glutamyl transferase. Mild to moderate elevation of transaminase, ALT and AST is noted. Leukocytosis, elevated white cell count, if cholangitis or cholecystitis is present, is noted. Tumor markers: CA99 can sometimes be elevated, mimicking gallbladder or cholangiocarcinoma. Imaging modalities: ultrasonography, the initial screening tool. Key finding is include a stone impacted in the gallbladder duct, dilatation of the common hepatic duct or the intrahepatic bile ducts above the level of obstruction, and the normal caliber common bile duct below it. MRCP, magnetic resonance cholangiopancreatography, the gold standard for non-invasive diagnosis. It clearly delineates the impacted stone, the level of biliary compression, and the presence of absence of a fistula. ERCP, endoscopic retrograde cholangiopancreatography, diagnostic and therapeutic. It provides definitive visualization of the biliary tree and compression, allows for emergency biliary decompression. Stenting or nasobiliary drainage can be done, but carries a risk of procedural complications. CT scan, useful for ruling out hepatobiliary malignancies which frequently mimic Mirizzi syndrome. The Nakagawa classification, it is based on the anatomical position and inflammatory stricture, making it easier to identify on the preoperative CT or the MRCP. The type 1, stone is impacted in the gallbladder neck or the cystic duct. Type 2, presence of the cholecystobiliary fistula. Type 3, stone is located at the confluence of the cystic duct and the common hepatic duct. Type 4, inflammatory stricture of common hepatic duct without a stone present in the cystic duct or neck is noted. The Sandys classification. The Sandys classification is most widely accepted system used to categorize Mirizzi syndrome, which directly guides surgical management. Type 1, extrinsic compression of the common hepatic duct due to a stone impacted in the cystic duct or the gallbladder neck. There is no fistula present. Type 2, a choledochal fistula is present involving less than one third of the circumference of the common hepatic duct wall. Type 3, a fistula is present involving one third to two third of the circumference of the common hepatic duct wall. Type 4, a fistula is present that completely destroys the common hepatic duct wall, which is more than two third of the destruction. Type 5, any type 1 to 4 plus the presence of cholecystoenteric fistula, usually cholecystodiurnal, which can lead to gallstone ileus. The differential diagnosis of the Mirizzi syndrome are the gallbladder carcinoma and the cholangiocarcinoma. Let's see the differences. In the etiology, Mirizzi is because of extrinsic compression by the gallstone. Gallbladder carcinoma, the malignant tumor from the GB epithelium. Cholangiocarcinoma, it arises from the bile duct epithelium. Clinically, Mirizzi presents with jaundice, right upper quadrant pain and the cholangitis. The gallbladder carcinoma, it has the jaundice, weight loss and the right upper quadrant mass. And in cholangiocarcinoma, it is painless, weight loss and pruritus. Imaging, there is extensive compression, impacted stone and intact duct in Mirizzi. In gallbladder, mass replaces or infiltrates the GB and has a disrupted anatomy. In cholangio, irregular duct wall thickening and delayed enhancement. Tumor marker, usually CA99 is normal in Mirizzi and false positives are possible because of the inflammation. Gallbladder CA has elevated CA99 and CEA, and also cholangiocarcinoma has elevated CA99 and CEA. Chorioembryonic antigen. Management. The definitive management of Mirizzi syndrome is surgery. The surgical approach depends heavily on the Sandys type. Medical stabilization needs to be done initially. The initial management includes IV fluids, bowel rest, and broad spectrum intravenous antibiotics, especially if cholangitis is present. Preoperative biliary drainage via the ERCP stenting may be required to clear sepsis and reduce jaundice. Due to extensive inflammation, a partial cholecystectomy may be performed after gallbladder decompression. 50 ml bile removed. Common bile duct explored via cholangiocatheter, multiple stones extracted. Bile duct stent placed for drainage. Surgical definitive treatment. Due to dense inflammatory adhesions in Callot's triangle, open surgery or an early conversion from laparoscopy is frequently preferred to prevent severe bile duct injuries. Decompression strategy. Percutaneous transhepatic cholangiography and drainage (PTCT) is performed, chosen over the ERCP due to high-grade obstruction and altered anatomy. Bilirubin levels are successfully reduced. The multidisciplinary decision, despite PET-CT suggesting malignancy, normal tumor markers provided crucial doubt. Decision is made to proceed with laparoscopic exploration rather than immediate radiological oncological resection. The intraoperative reality. Extensive adhesions are found. Callot's triangle is completely obscured by edema. A giant impacted stone is discovered at the gallbladder neck. The intraoperative frozen section confirms chronic cholecystitis with severe inflammation and malignancy formerly excluded. After confirmation of the Mirizzi syndrome, type when there is no fistula present, laparoscopic or open cholecystectomy is considered. Consider subtotal or the fundus first approach if inflammation is severe. Type 2 and 3, small to moderate fistula, Open partial cholecystectomy. Biliary defect is repaired with absorbable sutures. Choledocoplasty using gallbladder remnant or T-tube placement needs to be done. In type 4, complete duct destruction, open cholecystectomy combined with Roux-en-Y hepaticogenostomy. Complex bilioenteric anastomosis needs to be done. The final pathology, thickened fibrous tissue with lymphocyte or plasma cell infiltration is noted. Confirmed chronic cholecystitis with acute cholangitis. No atypical epithelium proliferation. Complications, cholangitis, biliary fistula, secondary biliary cirrhosis, bile duct injury during surgery. Follow up, 6 weeks post-operatively. MCP shows patent biliary tree with no strictures. 4 months post-op, patient is fully asymptomatic. Complete resolution of jaundice is noted. Mirizzi syndrome is an uncommon complication of gallstone disease characterized by obstruction of the common hepatic duct due to an impacted cystic duct stone. Early diagnosis with MRCP, ERCP, and appropriate surgical management are essential to prevent bile duct injury and achieve good outcomes. Thank you. That's all about Mirizzi syndrome.